I'm going to just give you a brief overview of what is happening in United States in terms of this COVID-19 outbreak and how um, it's impacting disproportionately to different communities. My presentation is very brief because I'm sure like you guys might be hearing some news about United States, what's happening and what not. But there are some aspects which are not often shared in international media. So I'm going to give you some statistics on disparities and how different communities are um, being affected here. So as previous speakers talked about it, this is the timeline, and this is timeline specifically related to United States. 31st December 2019, first case was actually reported in China. And I have actually highlighted some of the major milestones till now in the case of United States. You will see here on the slide, the first case was on 31st December, and the national emergency was declared on 13th of March. So you can see how much was the delay there. And meanwhile, the first death in United States was reported on the leap, the additional day we had in February, on 29th of February. But again, just a couple of days ago, CDC again confirmed that the community spread was well before in the country, and the first death in the country might have happened on February 6th. So like almost a month ago, what they were previously saying. So what I was trying to say here is there was a huge delay in the response from country, and nobody knows what to do and what not to do. Same thing happened in a lot of countries, and that is causing a huge toll in terms of cases and death as well. So this is the situation right now in terms of cases and deaths as of 24th of April. This gets updated every day in the evening. And you can see the darker the color on the map, these states are heavily, affected by this pandemic. And I must tell you, all these states which are in darker color, they are also heavily populated. So there is a high correlation between population density and spread of this disease. The next thing I want to actually point out is the disproportionate share of deaths and cases among different racial and ethnic communities in United States. As you can see here, after whites, African American had largest cases and even the largest death rate as well as of now. And there is a reason behind that. It is not a genetic reason. It is a socioeconomic reason behind that. And we may see similar pattern may emerge in developing countries where the socioeconomically disadvantaged communities might have a higher proportion of cases and higher proportion of deaths because their socioeconomic condition is very poor. Unfortunately, that kind of data has not been published from India or somewhere else, except US or developed countries. So it is very hard to say what is happening exactly. But I look forward to get such kind of data from from India and some other developing countries, and see how these communities are actually getting affected. in terms of real number. So as I was saying, there are some socioeconomic and health related factors which is causing this high case rate and death rates among African American population here. So obviously, the African American community here actually have a high burden of non-communicable diseases in terms of cancer. All these chronic illnesses are very high among African American community here. Their housing conditions are very poor. They are excessively criminalized. United States have a highest population incarcerated in the world, and majority of them are Black people, and they have been actually put into jail for petty crimes. So that is one major factor for having high number of cases in this community. Also, there are some medicine practice related issues like racial empathy gap. What that means is when a black individual goes to a physician for a health visit, actually the perception of that physician actually matters a lot. And and there are several studies which has shown that physicians sometimes perceive different symptoms in different racial ethnic communities. There were studies actually which showed when Black people actually demonstrate they have a show or say they have a pain, it is less likely that physician will prescribe them any pain medication. Vis-a-vis if there is a white person who actually complains about any kind of pain, they are more likely to get any prescription. So in United States, I would like to point out that as well. Unlike developing countries like India, here you cannot get medicine without a prescription. So that prescription matters a lot here. And that's why this racial empathy gap is a huge factor in terms of assessing tests for COVID-19 or getting treatment, getting hospitalization. All those stuff is actually goes through your healthcare provider. And that's why this factor has played a vital role. Also, as I said, the physician-patient interaction matters a lot, and Black community and individuals actually are less likely to receive any kind of attention, medical attention, as compared to their white counterpart. So that has also caused a lot of trouble here. The other important factor is the socioeconomic distribution and employment status of racial communities here. So I have marked some stark differences by red arrow. You can see Black or African American and Hispanic and Latino groups actually have a higher proportion of employment in service sector and production and transportation and material moving sector. This sector individuals actually handles a lot of materials and they interact with people a lot. And that's why these communities are more likely to get this infection. So this is a very important factor which has caused high cases and high deaths in these communities. And you can see Asian, which includes Chinese, Indians, and everyone, they are more in management, professional related services like IT or academics or management. And that's why they actually can take more precaution and than other communities. So that was one major factor. So moral of the story here is staying home is a privilege for many. And there are a lot of groups which are not able to actually have that privilege, and they are succumb to this infection. Besides this story of health disparity, it is also important to understand how communities are actually responding here. So one very starking example I saw here, and I'm also a part of it, the community actually helping medical professionals here. They are making their meals, they are delivering their tiffins to the hospitals, and nurses and doctors are overwhelmed by community support here. So that is a very, very happy actually example I could quote from here. And medical students, university students, and other community leaders actually coming forward, and they have made list of all the healthcare providers in their neighborhood, and they are providing them food. They are also taking care of their daily needs. They are shopping for them. They are going to grocery stores for them, bringing food, because healthcare professionals are not able to go out from their hospitals, and they are providing their services 24/7. So that is a very important community support they are getting. Um, another another important factor is how government have responded and how they have activated a statewide and county level emergency response system. County is equivalent to districts in India. So what they have done is actually they have created a website. This is not a new website. They already have well placed in their health department. And whenever such calamities or disaster happens, they activate this system, and they call for the volunteers through that website, through emails, and they reach out to the community, and individuals who have certain kind of expertise or whatever they can do, they actually register themselves to this centralized process. So there is no duplication of work actually. So what happens, whoever needs support as a volunteers, they reach out to the local health department, and local health department actually contacts these volunteers, and then volunteers gets notified via email saying that, okay, this place needs volunteers, and if you have time, please go there. So it is a very centralized process. And actually that, as I said, that can help avoiding duplicacy. I can see in India from the news reports, lot of volunteer organizations are coming forward and they are doing their bit. But it is quite possible that in the lack of coordination, there might be a duplicacy happens, or they might not be able to reach out to lot of individuals. So centralizing some stuff may help in that sense. Apart from that, local universities are taking very active role. So every university has formed their local research support group, and they are supporting their local governments as well. So at county level, just to give you example of my university itself, more than 100 researchers have come together who have interest in various aspects of this pandemic, and they have proposed a lot of studies, and they are providing some technical support to local county department and local state department as well. And not only my university, all the universities who are taking funds from government, they are sensing this responsibility, and they are providing very important technical support to government. So I guess this can also be useful in India's example, not only ICMR, but I guess local universities like which are funded by state COFER or maybe from federal fund, they should also come forward and do their bit, and support a response to this pandemic. So that is a very important example I could give from here. So all in all, that's all from my side. And I thank you, Mangesh, for providing me this opportunity. I will hand it over to him again. Thank you.